Thank you very much, Professor Ghoshal. Good afternoon, ladies and gentlemen. At the outset, I would like to thank Professor Dhiman, Professor Amit Goyal, and the CPLD team for inviting me here. And it's great to be back on this campus where I spent the best part of my life. So I have been asked to talk about for a motion for domiciliary use of human albumin in patients with liver cirrhosis. However, I'd like to reframe this slightly. Domiciliary means something taken at home, but often this is done as a daycare procedure and may even be done in patients for reasons I'll come to in a minute. And what we actually are concerned with is the long-term use of human albumin in patients with liver cirrhosis. So I'll basically speak on this subject. I'm quickly looking to differentiate between long-term and short-term use of human albumin. As I just mentioned, often for insurance reasons, for other constraints, in many centers in our country, patients are admitted for albumin infusion, which can actually be done at home or on a domiciliary basis. So the setting for the albumin use is less important than its duration. And quickly to differentiate between short-term and long-term treatment. What we are currently using and familiar with is short-term treatment given for a few days, maybe up to 2 weeks in an ICU setting to treat or prevent acute complications of liver cirrhosis, where you expect or want the benefit within hours or days, and as a result of which you use high doses of albumin for short periods of time, risking and pulmonary edema, as has been shown in some studies. And what we are talking about is human albumin use over weeks or months, often on an OPD or daycare basis to treat ascites, but mainly to modify the course of the disease for preventing complications. Generally, the benefit is noted a month or maybe even 2 months after initiating therapy, and so that is not a problem that one encounters in this subgroup. As the long-term use of human albumin is a different thing from what we are familiar with in the short-term use. And I'll come to show you data that long-term use of weeks and months has been shown to decrease the incidence and severity of complications, the need for hospitalizations, and may even improve survival and quality of life in a defined subgroup of patients. In fact, serum albumin infusions can actually be moved upon the only disease-modifying agent we have in the disease of decompensated liver cirrhosis, short of liver transplantation. It is used in appropriate doses and for sufficient time to restore and maintain physiologic levels of serum albumin, which is what is important for obtaining best benefit from this therapy. And generally 3.5 to 4 grams per deciliter is the target level. There are many challenges in this process, which I'll come to in my later slides. So quickly about what is albumin, what does it do? This 67 kilodalton 585 amino acid protein coded by genes on chromosome 4 has 6 dominant key binding sites, which are important for the A, B, C. The A is shown above, B below, and C effects of albumin. About ascites and oncotic benefits that we are familiar with. Also antioxidant, balancing redox states and binding transport functions. An important concept we need to be familiar with is albumin dysfunction in liver cirrhosis. The biologic benefit of albumin is dependent not only on its concentration, but on its functional capacity, which depends on the saturation of the binding sites that I showed a moment ago, depending on the toxin load, which is very high in decompensated and cirrhotic patients, as well as dysfunctional albumin moieties and hyperbilirubinemia. So that liver failure is characterized not only by low levels of albumin, but low levels of function of the albumin that actually is present, and resulting in the concept of effective albumin concentration, which is actually in CTPC patients much lower than the already low 2.5, 2.6 grams of serum albumin that we find. Short-term albumin therapy, I will not talk about because the indications, benefits are documented in multiple trials and studies and practice guidelines. The concept of long-term use of human albumin is 70 years ago in GCI, you had this publication for the first time in a small number of patients that started this field. And 70 years later, we have had what we can think of as a paradigm-changing study, that the ANSWER trial, in which 431 patients with uncomplicated ascites, relatively early liver failure, were given 40 grams of albumin twice weekly over 18 months, and what did we find? There was a 50% decrease in the need for paracentesis and the incidence of refractory ascites over this 18 months. Significant 30 to 67% decrease in complications like infective complications, renal complications, encephalopathy, and bleeding risk in these patients. And in fact, an improved survival was noted over 18 months in this subgroup. When they looked at hospital admission rates, there was a 35% reduction in hospitalizations and a 45% reduction in days spent in hospital, a 38% reduction in the hazard ratio for mortality as shown by this discrepancy in the blue bars. There are not all that much difference in the LT and the TIPS requirement. And this was achieved because the serum albumin level that was achieved in this trial within 1 month had gone up to about 3.5 to 4 grams per deciliter. Subsequent studies published at the same time again showed the benefit of this approach. And this post hoc analysis of the trial showed that the serum albumin target threshold of 4 grams per deciliter and the level achieved at 1 month after initiation predicted the outcome of therapy. Subsequently, in 2018 and 2021, we had the MARCH trial, liver albumin for the prevention of complications in patients awaiting liver transplantation, as well as the ATTIRE trial in which albumin infusions were studied in hospitalized patients with cirrhosis with an intention to decrease their complications. However, they failed to achieve their primary composite endpoints. And in fact, in the ATTIRE trial, there was a risk of pulmonary edema. And the differences were in the duration of therapy of human albumin between these two trials, which was very long, almost 14.5 months in the ANSWER and barely 2 months in the MARCH trial. The lower dose of albumin used in the latter study and the levels of dysfunction in the ANSWER trial, suggesting that albumin replacement actually works better at the earlier stages of liver disease, as we heard about sarcopenia management. Similarly, when we look at the ATTIRE trial, again, the duration was dramatically different. Only up to 2 weeks short-term use of human albumin was present. Although high doses were used, nevertheless, they failed to achieve the levels that are regarded as therapeutic in with albumin replacement. And possibly because this effort was made to achieve these high levels in a very short time, we had the impact of pulmonary edema, and there was no impact on survival benefit and complications. Now, what are the long-term challenges before we can actually talk of this therapy more routinely? One is that we need to identify a specific target population in the decom cirrhotics who will benefit, and possibly those with stable, less severe disease, MELD below 14, uncomplicated ascites who have not responded to diuretics, those recovering from complications or those with refractory ascites may be this target population. Biomarkers for response need to be identified, and normalization of serum albumin at 1 month is one such biomarker. Effective albumin concentration, hitherto a research tool, but which is actually in clinical practice, could be another marker, as well as inflammatory markers. Population and therapy, this was mentioned earlier this morning. What you're trying to do is fill the gap. As cirrhosis worsens, the albumin dips, and the gap between the optimal level and where you are has to be filled by albumin infusions. We need this. We can monitor individualizing doses and developing stopping rules. Cost-benefit analysis in multiple populations are required. And though some favorable answers were there in this ANSWER trial, formal studies, the Mexican study, they did not come out with definitive answers. Much of it depends on investment policies followed by health insurance agencies. The Italian Medicine Agency, where we did this trial, they reimbursed the albumin use for long-term use. In our state of Rajasthan, where I'm working now, the government schemes, they allow for albumin replacement to be reimbursed to the patients, and thus the benefit can be derived once these cost considerations are taken care of. So in conclusion, I would submit that long-term use therapy appears to be a disease-modifying intervention to decompensated cirrhotic, best practiced earlier in the course of decompensated cirrhosis over a long period of time, meeting set targets, that is to keep normal levels of serum albumin. And I agree that more work is needed. Specific subsets of those who will benefit need to be identified. Those duration points need to be better defined. Formal cost evaluation studies need to be applied to different populations. But I'm fairly well convinced. I hope I've tried to convince you that this is very going to be the way forward for the decompensated cirrhotics on wait list before transplant and those who are unable to achieve transplant. Thank you very much for your attention.